Thank you very much, Saki. Let me check. You see my slides, no?
Yes.
It's fine? Yeah. Well, thanks very much for the invitation and, of course, for giving me a very difficult topic. I must say, that's the point. I think everybody agrees. This is why I say it's still controversial after almost 40 years now since the early experiences of Dr. Federico Benetti in Argentina, which I'm, again, very glad to see him after a while. So, well, let me check. I don't know. Oh, yeah. So, yeah, sure. These are my disclosures, actually, because I tried all options. And after these 4 decades in the business, I prefer surgery. Of course, my knowledge is limited. And of course, I try not to go radical in surgical opinions. That's a fact. And these are my conflict of interest. Of course, my opinion is good, but not the only one. My opinion is good, but not necessarily the best. And of course, I have no moral conflicts of interest. So I think we need to go in this direction because, you know, it's an extraordinarily complex kind of topic. Then, if I'm saying this, my disclosures are those and my conflicts of interest are those, then the reaction from the public could be, first of all, you are outdated. Number 2, you are a bad surgeon. Number 3, you have no idea about the modern trends. Number 4, you do not want to teach the modern surgeons. And number 5, you're a dinosaur. So then the conclusion is that you should go home. That's probably quite easy. That's my perception of the business. But let's go quickly through this outline, try to refresh part of what happened before. This is clear. My statement, number 1, is surgical myocardial revascularization is the standard of care for patients with triple vessel and left main. That's, I think, a fact. And there is a bunch of evidence in the literature there from prominent people. And I think this paper a few years ago was also instrumental in that. However, let's have a look at that. The most studied operations ever in surgery are those 3 that you see here. Repair of hernia, about 20 million operations a year, according to American College of Surgeons data. In the US, there's more than probably 1.5 million operations for cholecystectomy every year. And this is what we see, coronary artery bypass. Almost 500,000 in the US. At the moment, should be something between 70 and 100,000 in China, and about 120, more than 150,000 in India, to say 3 major areas with a lot of people. And when you have a look at that, since the prominent contribution of clinic with René Favaloro and Brian Evler 60 years ago, we know that this is what happened. These are data from Germany and Switzerland. And then you could see that even today, coronary artery bypass represents a substantial proportion of practices in most of the countries, as we will see in different ways. Of course, we see on the right side how interventional procedures are just picking up very recently in the past few years. And if we come from the early papers on-pump, of course, from Cleveland Clinic, the late Dr. Frank Spence in New York, and so on, which is very well known. And the first from off-pump, the very classical from Russia, from Kolesov, and also from the group of Frank Gerbode in San Francisco. So this is still the discussion. So we see that, first of all, there are 2 options. Number 2, that we really had a lot of knowledge about what bypass surgery is after so many years. But, of course, that changes over time because this is a very dynamic process, and there are many other conditions that I personally call environmental conditions that you probably would agree or disagree. First, data from Central Europe. This is the German heart surgery report 5 years ago. You see 50% roughly are operations for CABG. That was 5 years ago, 6 years ago. And these are the data from Germany last year corresponding to 2022. So there has been, for different reasons that, you know, we are not going to discuss now, a decrease in the percentage of CABG in a large practice such as in Germany or even in Switzerland. So a 12% reduction. And you could see that about the percentage of off-pump is still in the low range, about 20 to 25%. Of course, again, most of these patients, they get 3 bypass grafts, which is more or less what everybody does. And if we move to Spain, we've seen that in different volumes. Of course, the pandemic had impact everywhere, but 6 years ago, about 30% of practice was coronary bypass. And in 2021, the latest that we have is about the same. 30% of the patients get coronary revascularization, with the percentages, as you could see here, of coronary bypass off pump, and which is basically 30%. So generally speaking, we may say that in Europe, this is more or less what this environmental factor brings to you in terms of data. In India, it's a slightly different thing. You could see here that at the moment, and this is a recent report from the former president, Dr. Howell, about 200,000, almost 200,000 CABGs are done in India at the moment, 60% off pump. And the recent report from Japan, in the annual report of the Japanese Society for Thoracic Surgery in 2020, you could see that the percentage is a little less. So there is much less proportion of coronary bypass in comparison to valve or aneurysms, and 60% off pump rate, which is similar also to that we see in Turkey as well. So that means that really it depends on where you are. People practice in a slightly different way. And these are also very recent data. I think it was about 2 or 3 weeks ago from China, which is a very interesting paper. I'm not really 100% in agreement, because this is just an administrative model. And then we know that administrative models and databases, they should not be used to implement things in the clinical arena. But you had a look in, especially in the east part of China, this data in 5 years, over 200,000 patients done in 700 hospitals, of 60% more or less are done off pump. So we have more or less an approximate idea how this works in different parts of the world. We know that. I think the ART trial, of course, was instrumental in giving us a lot of knowledge about many things, about type of grafts, and number of grafts, type of material, etc. And what we know after the ART trial in 2018 is that mortality is low. This is data from the German Surgery Report. And on the other side, that even today, for more than 30 years, the standard operation is Lima plus supplementary grafts in many different places, and the majority, depending on the place you work, on pump. Of course, this is more complicated than it looks. We know that at least the latest ESC guidelines, they show you different types of evidence that has been discussed before, so we are not going to go into that. And what is true, again and again, is to stress the fact that coronary bypass is the most important thing, or should be, according to guidelines, in recommendation for surgery for patients. You could see once more that for across all the classes of triple vessel disease, with or without diabetes, according to guidelines, they have surgery has class 1A in comparison to PCI, which is only reaching class 1A in 3 vessel disease with low syntax score. So this is known, and of course that might be modified in the future, but this is what we know at the moment. And the same for the patients with left ventricular dysfunction. Again, class 1B for CABG in patients with bad ventricles as well, which is part of the previous discussion that I really enjoy very much. And of course, there are other factors that help you in reaching a good decision between PCI and CABG, and I think that also the guidelines in Europe, they favor CABG, and under all these circumstances, which is more or less what everybody practices in this part of the world. And we also knew that CABG, conceptually speaking, has probably more recommendations for triple vessel disease and left main than PCI at the moment. It's clear that we all of us know that this is not a great deal, but then the point is to understand that we still the middle of a controversy in surgical myocardial revascularization. And I say that because, first of all, there are some technical aspects that drive decisions in CABG, once more in contemplated in guidelines, like, of course, Lima LED is a gold standard, class 1B, that the BIMA is also very good if there is low risk of infection. There are also differences if you are going to use skeletonized grafts, if the risk of infection is there. Of course, if you can use radial artery when the stenosis is really high grade. And although we have to go back to this seminal paper from the Cleveland Clinic, it is clear that the arterial graft, especially the Lima 2D LED, really has impact in everything over time for many, many years. This is, of course, part of the controversy now. In terms of, again, technical aspects, we see here that definitely off-pump plays a role. And this is what we knew, and we have collected over the past decade something, or 15 years, something like that. If we want to minimize aortic manipulation, if we have calcified aortas, if the patients are supposed to be high risk of, as it has been defined before, of course, we probably need to push for off-pump surgery, which is a regular practice in many places, as we have seen. So the question is, where should we go then? Should we go for on-pump or should we go for off-pump? So this is still today a problem. Whatever happens is that, and again, I think it's what we can take from previous presentations is once more institutional protocols and the heart team approach is probably the way to go, not only to revascularize the patients in terms of strategies, is also what we are going to do in the operating room. And I think this is probably an important message today. Again, there was a stress in many places, and when I was in Switzerland, that came up to reinforce this, the stress on that. But if we are going to talk about three-pep vessel disease and left main, I think the point is, the debate is the same. Is there a superiority of op cap over on cap? This is long lasting. I think even today we have a lack of convincing evidence for op cap for different reasons. Of course, incomplete revascularization and worse graft patency has been always advocated by many people. And I think our trial brought very interesting data to us. There are, of course, a lot of studies, as we will see in a couple of minutes, but then if we look at this data and the mortality at 10 years in intention to treat patients in this randomization between BMA and Lima grafts and no on-pump versus off-pump, of course, 10 years later, it worked very good. And the question was, why no difference between beta and zeta over the years, in specifically this intention to treat patients, which are supposed to be the majority of people that we are going to operate. Generally, no differences. Of course, surgeon experience counts in terms of the type of grafting that we do, and the surgical details, the postoperative care, and length of stay were, as you could see, not so different. And have a look at that. 40% of the patients were treated off-pump in both revascularization strategies with arterial grafts. So it gives me more confusion. So because you see that for the beta and the zeta groups, so on-pump and off-pump, they are more or less just shifting. So 56% of patients were revascularized with 2 mammary grafts, on-pump, and of course 60% with 1. And the off-pump is 40%, slightly less. So, and that question brought to me, when I read it a few times, more confusion, because my point is that despite we know that we are going to have a 98% survival 10 years down the road, then the point is that 40% of patients receive a different treatment strategy that was recognized in the trial. And apparently, and this is from, remember that from 2018, there was a difference in survival or in mortality as treated between single arterial and multiple grafts, considering that 40% of those patients were done off-pump. So this is very interesting. And when you have a look at the 5-year incidence of mortality in both match groups, in fact, there are little differences from this graph, which is slightly old at the moment. And again, what counts is the surgeon experience, which is a question that comes today in every single surgical trial at the moment. And again, when those data would match against the surgeon experience, of course, there were slightly differences over 10 years between single and bilateral mammary. I think that this more recent paper from those cardiologists in the JAC 5 years ago, I think Neil Smart did a very, very good analysis of that. And initially, you could see on the right-hand side is that whether we like it or not, that favored everything in every single paper tested at that time favored on-pump revascularization. Of course, there's things, but we are talking about 4,000 patients, more or less, with a relatively acceptable number of total events. So that meta-analysis was probably appropriate in my view. But when we finally go into the evidence or the lack of evidence, which is something that has also been discussed in the previous presentations, I think it's important to understand that sometimes we don't have it. I say that. So this is just an example of a paper which has nothing to do with coronary bypass. It's just a type A aortic dissection. But the main point in this paper published in JACC more than 10 years ago was exactly that. So the lack of evidence to recommend specific things to do in our patients. But if we have a look at the definition of high-risk patients in randomized controlled trials for coronary bypass, and you have a lot of them here, including the coronary, the German GOPCAVI, et cetera, we have different things. One is the definition of high risk that changes across every single study. And another thing is the definition of surgeon experience that also across these studies changes. So every different type of trial is telling you different things in terms of what we think, those who are in this webinar now, about what high risk is and what the surgeon experience is. And I think it's still controversial. But when you have a look at that, and John Pascas went through that just a few years ago, analyzing 76 randomized control trials, comparing on-pump and off-pump, it was clear that off-pump patients had less number of grafts, and they had more 30-day graft occlusion, and also 1-year repeat revascularization. So initially telling that from randomized controlled trials, which is a higher level of evidence, initially off-pump was not working so well than on-pump. And this is coming from the analysis of multiple data. But again, this data from SMART and other one in New England Journal of Medicine 16, the built-in evidence is that probably the survival advantage of on-pump could be attributable to higher incomplete revascularization and worse graft patency again and again, which is what it pops up in every single study. Then it came the Ruby, which was also heavily criticized by surgeons doing only off-pump, because they, of course, claim that the experience of the surgeon counts, which of course it counts, like any other operator across any other type of things that you need to do, like echocardiography or like interventional cardiology, et cetera. But of course, that was criticized. And also this study from the VA system, from the Ruby trial, also said more or less what you say, that that off-pump seems to be worse than the other strategy, which is, of course, still a matter of debate. And it was a quality of revascularization data on the follow-up. And they say, of course, that the circumflex system is effectively revascularized better with on-pump, that the right coronary arteries effectively revascularized better in the on-pump strategy, and the patient is overall much better vascularized when there is on-pump than in the off-pump strategies, which is fine. Then this big study from Germany focused only on the patients above 75. Arno Digeler and did a very good job with this fund. And the GOP-CAVI told us that when we analyzed the subgroup of patients above 75 years of age, then the 5-year survival was similar between both groups, but incomplete revascularization was, of course, associated with a lower 3-year survival respective of surgery. So we get more, I think, more confusion than before, but it's clear that maybe these two major data must be taken into account all the time. Then Joanna Chique, and when she was at New York with David Adams, they came with this thing which was focusing on experienced surgeons. There was also more confusion to the point. So in this study, they compared these huge populations, and then they defined experience with at least 100 patients operated on pump or off pump by the surgeons. So the trends in OPCAP were more towards a single vessel disease with preserved left ventricular function. So I think every single slide makes the thing more complicated to me. And we are talking in this slide about real big populations as well. But from that study, of course, despite there was no difference in myocardial infarction, new dialysis, or stroke between on or off pump strategies, OPCAP had more long-term mortality in volume qualified surgeons. That means 90% plus. So again and again, there are 2 or 3 major factors that pop up in the screen every time that bring also a bit more confusion to us. Then at the bottom, something for the future is we should look into other alternatives, which might be non-cardioplegic on-pump, robotic, which is becoming more popular, especially in the US, or hybrids. I personally have some doubts about hybrids. But for instance, the data from Portugal, when Manuel Antunes were there, in a huge cohort of patients of more than 8,000, they found that, of course, there was an inverse relationship between the performance of the surgery on pump without the aortic cross clamping, as you could see here. And of course, the incidence of cerebrovascular accident was just kind of undergoing a swinging pattern over the years. And they are talking about 8,000 patients over 20 years, although these are a bit old statistics from 10 years ago. But of course, they had, in my view, excellent results with this type of strategy in terms of graft number, in terms of infection, in terms of stroke, and in terms of every complication that we can analyze with a very low hospital mortality. But not sure if this can be extrapolated or not. And finally, then that shows you that we are still having problems in defining exactly what is the best. Harold Lasser, good friend of us, came with this thing in circulation, so that there's a strong question: should off-pump coronary artery bypass grafting be abandoned? That's fine. Major issues: risk with conversion, incomplete revascularization, inflammatory response, stroke, and quality of life, especially focusing on mental health scores. There were retrospective studies, there were randomized trials, there were meta-analysis, and he said that we had no significant improvement in short-term morbidity and mortality for OPCAP. But then Bruce Lytle, also in a phenomenal editorial, although it's about 15 years ago, the problem when he analyzed all these data, say, okay, the weaknesses of studies is that others do not examine the association of this strategy with other surgical variables, which is again and again complete vascularization or the use of internal thoracic graft. And that the benefit of on-pump strategy related most in situations, and I think we have more light now, in which revascularization is more complex. And on the other hand, low-risk patients do not seem to pay penalty for on-pump surgery and may receive more revascularization. So it's always the same thing. And again, Joanna Chique can say, okay, guys, so what is experience for us? And they say, experience off-pump surgeons averaging about 500 off-pump cases and performing more than 80% of the cases. rate of incomplete revascularization, late mortality are significantly worse with off-pump surgery compared with on-pump coronary bypass. And then in that environment in the state of New York, they say, okay, for most patients without contraindications to cardiopulmonary bypass undergoing surgical revascularization, on-pump bypass remains the appropriate choice. So it doesn't matter where we go. Now, going to sex and other things, I think this paper from Mario, I think Dr. Fremis is here, participated. They focus on sex differences in bypass surgery, and they say that women had worse outcomes than men in the first 5 years after CABG, but the difference is not really much affected by the surgical technique. So that means that off or on-pump surgery and using multiple or single arteriografts, they don't really have an impact on the survival, which is also a very interesting observation. And also in different types of things, complications like, again, Mario Gaudino and the group say, okay, 5 years later, what happened after these patients when they are undergoing an operation for surgery, coronary bypass off pump. And again, they found more or less the same. Of course, this is just less than 5 years follow-up with 8% readmission rate in 4,000 patients. So there is no much difference, as you could see statistically speaking. So finally, and this is from just a couple of years ago, once more, the ART trial is bringing, I think, important information for us. Prominent colleagues, as you could see, as you know very well, they match these patients, more than 1,000 per group in off and on pump. And actually, there is no much difference in terms of all-cause mortality or death or major events on the right-hand side. And the same in terms of absolute risk for all-cause mortality and major events, and concluded that the findings of the ART trial comparing off and on-pump techniques achieve comparable long-term results. However, and again, when off-pump surgery was performed by low-volume surgeons, that was associated with lower number of grafts, increased conversions, and so on, which is something that we know and have more information at the moment. So the point is, should be, we have to wait for the Roma trial, which is supposed to be completed, Dr. Fremis, correct me if I'm wrong, in 2025, expecting more than 4,000 patients to see if the strategy in terms of revascularization, they're going to be different. I'm not sure if this is going to be affected by the on or off pump controversy, but maybe this is going to be an important trial, as we have discussed in the past. And probably, and I think this is a very important point, that again, Mario and David Taggart, they put that a few years ago, and I think this is also my point. 50 years after the first case is done by any of the pioneers in coronary bypass surgery, coronary artery is still an art, and I think still an art. This is part of the surgical art, because I think this is exactly what happens. So to conclude, I have to say that, first of all, I have no idea of what is best, and I think that probably many people would agree with that. First of all, this is a very complex scenario because there are multiple factors involved. Second, off-pump CABG is absolutely safe. However, all types of studies have shown no superiority of on-pump over off-pump. This is what I can incorporate from the literature. Of course, there are well-established differences in graft patency over time. And my point is that we should avoid going conceptually radical in surgery, because probably the point is that all these strategies, they should not compete. They are more or less complementary. And this is at least what I have learned over the years. I really thank you very much. And I hope that this has not been just a kind of a boring thing for you. Thank you very much.